Hey everybody, welcome back to another lesson. And in this lesson, we're going to cover two topics. The first being substance abuse and poisoning, and the second we're going to tag on allergic reactions here. And so different topics, but they actually are related, right? Because they're both referring to things that are coming into our body and changing how our body maintains homeostasis. So just make sure you get everything as we go through here, and watch it again if you have any questions at the end. All right, so first let's talk a little bit about the anatomy and physiology of not just poisoning and overdose, which is what we're going to start with, but it does apply to allergic reactions a little bit as well, because we're taking stuff into our body and our body is dealing with those substances, whether it's peanut butter or methamphetamines, right? So there's kind of four physiological steps here when there's anything coming in. So the first step is absorption, right? How do we get stuff into our body? And I got a couple example pictures here. So you could ingest things, directly take them in and swallow them. They're going to get absorbed into your bloodstream through digestion. Inhalation's another factor, right? Coming up in through our nose, and there's lots of blood vessels up here. They absorb directly into your bloodstream. You can absorb things through the skin, right? And a lot of times we see medicated patches like this, whether it's nitroglycerin patch or other types of patches, where you can absorb any medication through your skin directly in your bloodstream. And then, of course, IV or intravenous, where you can inject yourself, right, directly into your bloodstream. So, all four of these are different ways that you can get stuff in, but they all eventually get that chemical or substance into your bloodstream, which brings us to distribution, right? So your body moves stuff around through your circulatory system. But your circulatory system is the highway for your body to move everything around: oxygen, food, hormones, chemicals. So all of these are going to take a ride through your circulatory system. Your body then breaks down those foreign substances, those chemicals, over time. And your body is actually really good at breaking down toxins and foreign substances, especially organs like your liver, right? And even your kidneys help filter out a lot of that stuff. So a lot of times what we see with people who suffer from substance abuse, whether it's alcohol or hard prescription drugs or whatnot, is we do see a lot of liver damage over time because their liver is just being so overworked in terms of filtering the stuff out. And then finally, elimination, right? How your body gets rid of that substance, whether it's through your urine, to filter out through your kidneys to get rid of that stuff. So two other items that we see here we need to think about, right, is substance abuse. And that's when basically anytime we're using a substance that's not for its intended purpose to try and alter a mental state or a physical state, all right? And somebody who suffers from substance abuse could also suffer from addiction, right, which is basically you can't function on a normal level without having those substances in your daily life. Okay, and that's what addiction is. So this is just a quick list of like many of the different types of drugs we'll see out there. And you got to remember, like, these are drugs, and we also have all sorts of poisons and dangerous chemicals that could also have mind-altering effects as well as physical-altering effects. All right, but some of the biggest categories would be like acids and bases. And you can see we have some sulfuric acid over here. That's more you're going to see in environmental emergencies, whether it's manufacturing plants, chemical plants, school chemistry departments. But they are really dangerous. We had an incident in Burlington in 2020 at Buffalo Wild Wings where a worker mixed two cleaning agents, an acid and a base. I believe it was some sort of ammonia-based and a bleach-based. Had a really terrible reaction because acid and bases created toxic gases, which evacuated the whole restaurant, and the manager died trying to get everybody out. So it's not uncommon for us to see these types of things. In terms of some of the other drugs that we might think about as mind-altering drugs we might run into, would be anti-anxiety drugs, antidepressants, right? So like your Prozacs for patients who are depressed, which are kind of act as little pick-me-ups, as little stimulators. All right, antipsychotic drugs for somebody who might be suffering from bipolar disorder or schizophrenia, something like that. Then we see our depressants, right? So drugs that kind of slow you down, like alcohol would be probably our number one depressant. All types of designer drugs that are out there, club drugs we call them, and there's so many different types. And it's important to remember that we have, it seems like every year there's new types of drugs that are coming out, and new ways that people are going to abuse different chemicals. Okay. Moving along, we have hallucinogens, inhalants. So again, things that you might inhale, right, or huff, and they can come in all types of cans. Hallucinogens are things that make you imagine different things going on. Opioids, all right, are probably the number one. We're going to talk a lot about opioids. Um, Number one drug that we see out there on the street right now for different reasons. And we'll talk about that not only from an illegal drug, but also because many of our painkillers like Oxycontin, Percocet are based on their opioids, right? And we can see some of those here. Nerve agents and prescription drugs, right? Which you'll see they're kind of related. So these are our categories, and as you're seeing, right, some drugs fit into multiple boxes of these. So it's just important to remember while we're doing our patient assessment, looking around the scene, not only assessing the patient, but what we may see there, trying to put together some of these clues for what may be going on with our patient. Okay, so on this slide, I included just a couple of our common illicit drugs that we might see that are some of the more prevalent ones that we see in society that people are abusing and may be addicted to. So the first one would be methamphetamine, all right, which it's also referred to as speed or meth or crystal meth, all right. And if you ever watch, and this is a picture of some meth right here, but if you've ever watched Breaking Bad, all right, that's what they are in right there, the meth industry. And meth is a really powerful stimulant with a high potential for abuse and addiction. Basically, when you get hooked on this stuff, it's very hard to get off. It speeds you up. It gives you a really big high. And it's just a very powerful drug. So it stimulates you, can make people seem somewhat psychotic, acting crazy, and really stimulates them. It's not a depressant, right? So that's methamphetamine. Something else to think about with meth too is the way they make it, right? It's actually made from a cocktail of different types of drugs that are extremely volatile and extremely toxic. So in dealing with methamphetamines, a lot of times you may have heard of a meth lab, right, where they cook these things up. And those can also be different emergencies we respond to because the hazmat team is going to go. You can have a lot of people could be poisoned just from breathing in the fumes from the meth labs, and they could also be very explosive and dangerous situations. So we might even be responding to a meth lab as EMS providers. Okay, our second one I included here would be opioids. And this is probably the most prevalent that we're dealing with in the past, I'll say 5 to 7 years in the United States. We really have had an opioid epidemic in some sorts because it's a national crisis, all right? And the reason that people get hooked here is I put a picture of this one in, the Oxycontin, which I'm sure you've heard of, which is a painkiller drug, right? Your Oxycontin, your Percocets, they ease pain, they really kind of knock you out, mellow you out. And really this whole addiction started because doctors were over-prescribing these painkillers for after surgery or somebody who hurt themselves and was in pain. And once their prescription dries up of OxyContin, somebody's hooked on it. They need that fix. They're going to jump over to heroin, right, or some other opioids available on the street to try and fill that gap there because they're addicted. All right, and most people who become addicted will eventually die. And we're going to talk. Luckily, we do have some tools to help somebody that's overdosing from an opioid overdose, and we'll talk about that in a minute. But the bigger picture is getting long-term care and getting off these drugs. Really hard to do. And then another one we might see is PCP. Maybe you've heard of it as angel dust. And it used to be a tranquilizer. All right, this is one of our big club drugs here. Also a stimulant, could really cause some hallucinating, like we might see in some of our other drugs. So those are just some of our three big ones here, but opioids particularly is what we're going to focus on for treatment. Because for most of these other ones, there's not too much we could do in the field as basic life support providers, except, as we'll talk about here, what we can monitor. So when we're doing our assessment, right, making sure the scene is safe. So if you're responding to some type of party or a club or a drug event, just being aware of who's around you and, could there be illegal weapons? Could the scene turn unsafe for you? All right. And also, like we talked about with meth labs and whatnot, is there going to be hazardous material around? So Do you have the proper gear to go into a scene? Do you need full respirators, SCBA type gear? Okay, like hazmat we see down here. Our primary assessment is going to be the same, right? Looking for life threats. We're going to try and figure out right away if this involves poisoning or substance abuse. And we're going to really use the scene. So do we see pill bottles? Do we see any spray cans if somebody was huffing spray cans, right? Do we see needles or other type of drug paraphernalia around? Okay. You're going to look for the patient for evidence to exposure. So, if it is some type of toxic chemical, maybe burns around the mouth or nose. If you do expect some type of overdose, looking for needle stick spots in the arm or hands or feet, or track marks, which we'll see, which are from shooting up in your veins. So really looking for those, using our detective skills here to try and figure out what's going on. And in terms of management and transporting the patient, and you can see here I included just, any of the stuff that you might see here, needles, bongs, drugs on the floor, scales, all types of stuff. Just really trying to give you a clue if that is some type of opioid or overdose. So in terms of treating these patients, the biggest thing here is our ABCs, okay, for any of these. Because with most of these drugs, what really happens is it affects either the B or the C, all right? It's affecting somebody's breathing and their ability to have that automatic control of breathing, right? So we need to think about bagging them right away, making sure that they're getting high flow oxygen. If they're not breathing for them. And on some of these stimulants especially, it may have a big cardiac effect and affect the cardiac output. So we need to be looking at that, looking at their pulse, looking at their vital signs, getting them on a monitor, so making sure ALS is coming, and also be prepared to do CPR, especially if they stop breathing and then their pulse stops, okay? So really, really the key here is respiratory, right? Monitoring their respiratory status for any changes, okay? And it's really those ABCs. All right. So with any type of poisons, though, all right, and this is something every EMS provider should have on their phone is poison control. And I thought I had the number here, but it's a 1-800 number. You can call 24/7 and get some advice from these lovely poison control people here on what to do for a specific type of poison. With drugs that you may find, it's whether it's prescription or whatnot might be hard, but in terms of chemicals or if you see anything else going on, poison control is a great number to have. And of course, I threw in some of our ALS providers here. We want to make sure we have ALS coming. Okay. So what I want to talk about is we're going to talk a little bit. We can treat opioids in one other way here, more than what we could treat some of our other illicit drugs that we may find. And I'm sure you've heard in the news Narcan or Naloxone. All right, so Narcan or Naloxone, which we'll get into how to use it on the next slide here. It's basically a drug that reverses the effect of opioids. So whether it's heroin or Oxycontin or Percocets or any other opioid out there. All right, and the way that, I guess we'll talk about the way how opioids work first, right? Is your brain has all these receptors, which are symbolized by these green lightning bolts here. All right, which actually regulate your respiratory drive, okay? And what happens here is when you take opioids and they go through your bloodstream, they go to your brain, they actually bind to these receptors and it keeps your brain from telling you to breathe, which is why the biggest thing we see with opioid overdose patients is they're not breathing, okay? So we see, and they're unconscious, obviously, or some type of altered mental status. So these opioids bind to the brain receptors and stop you from breathing. So basically what naloxone does is it's this chemical, all right? Narcan is the commercial name for the drug naloxone, and it comes in and it kicks these opioid off the receptors for a short amount of time, and the person starts breathing on their own, and they'll usually, hopefully after a couple doses of it, will maybe even regain consciousness and be totally awake and normal. The only thing to remember is that this naloxone will only last for anywhere from 15 to 30 minutes. And if there's a lot of opioids in the system, they're going to come back and that person will go unconscious again. So it's really important that we don't just give somebody Narcan, it frees up the opioid, they're back to normal, and just leave them because they could crash once we leave. All right, so that's how naloxone works. Basically, it frees up these receptors in your brain. It kicks the opioids out so you could start breathing again. All right, so most of our pretty much statewide now, right? For opioid emergencies, we carry Narcan, all right, which is the drug naloxone, okay? And it comes in these atomizer sprays. It's a liquid that is intranasal, so you spray it up the nose. And I included a little screenshot of the state protocols here. So basically, here's our little note here, right? It's only for suspected opioid patients with diminished respirations and respiratory rate. We may have to ventilate them as well. And you can see here, basically a first responder, so police or fire or EMTs can do this. And it's 2 milligram to 4 milligram via nasal atomizer. And they do make auto injectors, but the nasal atomizer, nasal spray, is the most common one. If there's no response in 3 to 5 minutes, we give a second dose, okay? And you can see here, basically, this vial has 2 to 4 milligrams of it, so we do half a vial in one nostril, half a vial in the other. It gets a really nice misty spray of that drug, which gets absorbed through the nose and will go right into the brain to knock those opioids off the receptors there. So again, we're waiting 3 to 5 minutes. That could be a long time. In the field, I've seen that we can go pretty quick on giving these. And, we can only give 2 doses, but I have seen some ALS providers give a whole bunch of doses to really try and get somebody. The cool thing about Narcan naloxone is that there is no known contraindications, which means I could spray this up my nose right now and it would not affect me. If there's no opioids in my system, it's not going to affect anything. So it's one of those things where if we have somebody of usually a younger crowd, or just something that seems off, why would this person be unconscious and not breathing? We can give them Narcan if we have a hunch, and if it turns out they were not unconscious or not breathing because of an opioid overdose, it won't really have any effect on them. All right. The key thing here is that if the patient wakes up, they are on this super, super high, right, and unconscious, and now all of a sudden, if you know anything about drugs and being high, right, once you are off that high and you come back down, it's a super, super low. It's like a huge roller coaster, right? So they're going to wake up, not know what's going on, not know who you are, and be really, really angry and upset and have this huge withdrawal. So got to be ready that they might try and hurt you. So definitely having police there and extra providers to help you out is a big thing. All right, so that's kind of it on, again, that's just a quick split-second overview of poisonings and overdoses and using Narcan for opioids, but it's a really important skill to know. So remember, the biggest thing, and especially if it's not just opioids, but any other substance abuse, our ABCs are key. All right, getting ALS on the way and making sure we're maintaining ABCs and getting them to the hospital for a higher level of care. All right, so let's switch gears here and talk a little bit about allergic reactions. All right, and it's funny because it is in a way related to poisonings and overdoses because it has to do with substances that are coming into the body and creating an immune response, right? So our body is still responding to something coming in here. And I put a couple different pictures up here, but there's all types of things that can cause allergies. Like I know I have seasonal allergies when the pollen count is higher, if things are moldy, all right? But other things that might cause more severe allergies would be like nut allergies, milk allergies, fish allergies, seafood, right? Usually lots of foods or things that we take in from that. Pet allergies, okay? And there could also be allergies from medications. So like I have seasonal allergies, and I'm sure most people do, and it's not that bad. But you can have a severe allergic reaction to some things. And the technical term is called anaphylaxis. And that's what we're really caring about in emergency medicine is anaphylaxis. Not so much allergies, but an allergic reaction that can result in life-threatening shock, right? So really affecting our circulatory system and our C, right, ABC's circulation, our ability to get blood and oxygen to the rest of our body. All right, and I kind of threw this picture up here because I really like it. So a big one we might also see in the summer is people are allergic to bees, right? And the bee venom, right, gets into the skin, gets into the bloodstream, and without getting too much into it, right, essentially it makes our immune system say, "Oh, we have an invader." So it creates a huge immune response, which causes this anaphylaxis. And the key thing to think about here is it's going to affect really 2 systems: our circulatory system and our respiratory system. So getting air and oxygen in and then moving it around. So really, really dangerous stuff here if we see anaphylaxis in a patient. So what are some different reactions going to look like, right? So maybe you've heard of histamine, maybe you've heard of an antihistamine, right? It's a chemical that's released in your body during a allergic reaction, okay? So if you take something like Benadryl or something like that, that's an antihistamine. So if you're having mild allergies to, pollen or whatever, you might take some to reduce that histamine to stop any swelling and whatnot. So, but we could see some severe side effects. So bronchoconstriction, right? Swelling of the airway, vasodilation. So your blood vessels get really big. Your blood pressure drops, hives, itching, and pain. All right. And we kind of have three different categories here of allergic reactions. So our first one is our mild one. So if you've ever gotten a rash or hives, also known as urticaria, all right, that's a sign of a mild reaction. And maybe you might see this with even poison ivy, right? You get hives, flushed, itchy skin, all right, pruritus, tingling in the mouth. And now we start to see, as we get down the list, we get a little more severe here. And we need to remember, right, we're not going to give every patient an EpiPen. If someone's having a mild reaction, just some hives and maybe a little itchy, that's not life-threatening, right? We're not going to give them a really powerful drug like Epi. But as we start to think about those two systems, right, our respiratory or circulatory system being affected, that's life-threatening. We need to think about those. So watery reddened eyes, yeah, it stinks, but it is what it is. Being tired or run down. All right. As we get into our moderate into now, and I'll include some of these in severe as well. All right. But, this is starting to be serious. And we can see here this angioedema or swelling of the tissue in the face, right? You can see this kid's little eyes and face are swollen. Her tongue is really swollen up. That's getting into really serious we have it as moderate here, but I would consider that pretty serious because if their face is swelling up, that means their airway is swelling up and we can't get air in. They could suffocate. All right. So if you see any of this, that's a big warning sign. All right, time to get some epinephrine out here. All right, but with these moderate, we might see hives, itching is worse, pale or flushed skin, red skin, and again, that swelling of the mouth is not good. All right, but then we get into these included with the severe allergic reactions and anaphylaxis would be basically affecting these systems. So respiratory, right? That high-pitched wheezing, swelling up of the face or throat. Your skin is getting really, really pink, like we said. Your circulatory system is getting affected. So why is anaphylaxis so dangerous? Well, we already said about swelling up your airway. You can't get air in. All right, bronchoconstriction and bronchospasm. So in your lower airway too, the bronchioles start to tighten up and they fill with fluid. I think I have a picture on the next slide here. They fill with kind of fluid and mucousy and constrict, so it's hard to get air in. All right, your blood vessels actually dilate, which means they get bigger, so vasodilation. And that's not good because your blood pressure is going to drop. And we know we need blood pressure to move our blood around. So all of a sudden, if you can't breathe and your blood pressure drops, right, those are two things that you don't want to happen because you can go unconscious and die right there. So that's why anaphylaxis is a really, really life-threatening emergency. Okay? So thinking about our patient assessment, right? Get that sample history right away if you see somebody that looks like this. And obviously in sample allergies is what you want to pay attention to. And not only food allergies or environmental allergies, but also medications, right? Maybe they took, amoxicillin and they're allergic to it. So getting that allergies out of the way right away. Ask if they've had previous allergic reactions and asking if they've had anything similar to this, all right? And of course, we've all heard of Benadryl or Claritin, some of those other ones. So sometimes, and again, this goes back to like that more mild reaction. Now, as EMS providers, we can't just give Benadryl. It's not in our protocols, all right? But a doctor might give Benadryl. A lot of times, if we have a pediatric patient and their parents are used to them having allergic reactions, they might start off by taking Benadryl, right? An antihistamine to try and help that. But, if your airway's swelling up and your blood pressure's dropping and you're really having difficulty breathing, Benadryl is not going to cut it, okay? We definitely need to get ready to give some epinephrine, all right? So epinephrine is a drug where it does the opposite of what we need or of what's happening in anaphylaxis. So it's a vasoconstrictor bronchodilator, all right? So it's going to open up our airway and it's going to close or constrict our blood vessels, which opened up, so get our blood pressure back up. All right, so this is a really, really life-saving drug, epinephrine. The only downside to it is it's a really, really intense drug. It can really affect the cardiac circulatory system immensely. So we just need to be really, really careful about using it. Okay, so like I just said, promotes bronchodilation, vasoconstriction, so trying to get us back to normal. And EpiPens usually come, so we see more of these. They're more common now in these little square things that you push into the side, but it's an IM or intramuscular injection. And I'm sure we've all seen these EpiPens around where you take the blue cap off, the orange side is a needle, stick it right into the thigh, hold it for 10 seconds, and the drug epinephrine comes out. Okay. These were in the news a lot last year, especially because they were becoming ridiculously expensive. Drug companies were pushing the price up more and more and more, so that one EpiPen was costing anywhere from like $600 to $800 per EpiPen, and the drug expires every year as well. So really expensive for everybody to have for a basic life-saving drug. So it's great. The auto injector is great because anybody, a kid, if they are allergic, they're going to carry this with them if they have an allergy. And if they're having those severe symptoms, right, they can inject themselves and hopefully save their life, all right? Or a parent could do it to somebody else. So like I said, they're getting really, really expensive, all right? And one other thing to think about is if you have to use an EpiPen, you need to be calling 911. We need to be on the way as EMS because just like when we talked about Narcan, the drug only lasts a little bit. Well, same thing. The epinephrine's only going to last so long. So in 10 or 15 minutes, the reaction might come back and be 5 times as worse, and that patient could die. All right. So they usually come in 2 to a pack here, that the patient has 2 doses. But like I said, they're getting really, really expensive. And we used to carry these on ambulances, but because they are getting so expensive, what we actually do now is the check and inject program. So it's actually much cheaper for us to carry all the parts to do like a real injection, not using an auto injector, which is a newer skill for BLS providers. And you can see I included it here. This is a medical director skills here. Medical director has to sign off on it. But I would say almost every service in the state, and this is becoming nationwide too, is using this check and inject. And basically, you have a syringe, you have a vial of epinephrine down here, and all the other stuff that you need, some Band-Aids, some prep pads and whatnot. But this is a really important skill to practice because depending on our patient, we might have to give different doses. So you can see here in the state protocols, right? The adult is 0.3 milligrams IM only, and a pediatric dose is 0.15 milligrams, so half the adult, and that's for less than 25 kilograms, which is about 50 pounds, 55 pounds. Okay, so the reason that this is a lot more dangerous than the auto injector is because an auto injector had only 0.3 milligrams in it, and the EpiPen here we call it, and once you stick that in, boom, you deliver the 0.3. This you need to be really careful about because you can draw up into the syringe a whole milliliter or milligram, I guess, of epinephrine, which that would kill somebody, okay, depending on the patient and if they have cardiac history. So we call it check and inject because it's a really thorough, redundant process. So we need to make sure that the patient needs it, right? We're not just giving it to somebody who's got some hives and is itchy. They have angioedema, they're having difficulty breathing, they have swelling of the mouth, low blood pressure, okay? We're going to make sure we have the right drug, the right dose, the right medication, the right route, the right date. We're going to check to make sure that it's for IM and not intravenous injection. And then we're going to draw it up through, we're going to need to sterilize the vial, we need to sterilize the patient arm. We're going to draw it up and make sure we have either 0.3 milligrams for an adult or 0.15 for a pediatric. And then we need our partner to double check everything. And this is where the check and inject comes in, is that we're having both of our eyes go over it. So we're all looking to make sure we did everything. We made sure that the patient actually needs it. And our partner is going to double check our dose. And if they don't like it, if they say, oh, you took up a little bit too much, you got to restart it all. Okay, so really double checking that we don't have any serious issues here. And then just like an EpiPen, the only nice thing about this is we can actually inject it into the upper arm. Which is usually a little bit easier than trying to get down to their mid-thigh because you can't go through heavy clothing with this little needle like you could with an EpiPen. So again, you can see this is a newer thing here. We've been doing this for about over a year now in the state. But it's really helpful because it's way cheaper like this, and it's better for us to be able to give patients drugs when they need it, right? That epinephrine to really save a life. So that is all I have on allergic reactions. Again, just being aware of this in our patient. And this is, again, one of those things where our sample history and getting our assessment as quick as we can while we're, getting on scene and assessing, the longer we wait to address an allergic reaction, the worse off the patient's going to be. So getting this right out of the way at the beginning, and looking for those severe signs, the bronchoconstriction, the vasodilation, tightening of the airway, difficulty breathing, facial swelling, that's all stuff we need to be looking for. So I know that was a longer lesson, but we covered two big topics here, and let's be prepared to go over some of those practical skills. So giving epinephrine and giving Narcan, Naloxone in class. And hey, stay tuned. Thanks for watching. See you on the next one.